Ayoub. He is my colleague at Cedars-Sinai Medical Center, full professor of medicine. He's going to be talking to us about updates in PBC and PSC. He's our local expert on cholestatic liver disease. He runs many clinical trials, and I will give him the floor. Thank you.
Well, good morning, everyone. Thank you for staying to the last part of the symposium. I'd like to thank the organizer of this meeting for giving me this chance to give you an update in the management of PBC and PSC. These are my disclosure. And today I'm going to be giving you updates, what's new and coming in the management of PBC and PSC. I'm going to cover current therapy and upcoming therapy. And we're going to touch on new treatment coming up for management of pruritus in a patient with cholestatic liver disease. So primary biliary cholangitis, it's autoimmune-mediated liver disease. It's characterized by an immune injury to the bile duct that eventually lead to bile duct loss and eventually bile acid buildup. With time, scar formation develop in the liver, leading to advanced fibrosis and cirrhosis. In the early stage of the disease, we tend to see elevations in alkaline phosphatase, where an elevation in the bilirubin is more indicative of more advanced liver disease in patients with PBC. PBC is a disease of female predominance. On average, it's estimated that 1 in 1,000 women over the age of 40 are currently living with PBC. And usually these patients has other autoimmune disease seen with them, such as thyroid, celiac, to name a few, in addition to CRUS, which tend to be common. To make a diagnosis, a liver biopsy is not usually indicated. Actually, a patient needs to fulfill 2 of the 3 criteria: presence of cholestasis, or elevations alkaline phosphatase, presence of antimitochondrial antibody or other PBC-specific antibodies, or presence of a supportive liver biopsy histology finding. But the patient, as you could tell, if they have cholestasis or a positive AMA, you don't need to do a liver biopsy to make this diagnosis. AMA is quite sensitive for patients with PBC. It's found in 95% of the patient, and in the general population, it's estimated to be present in an extreme minority, 0.1%. Common scenario comes up is what to do with patient with isolated AMA and no evidence of cholestasis. There was a study done in France. They looked at a laboratory test result from 26 laboratory centers as they isolated patients who were found to have a positive AMA and no evidence of cholestasis or elevation in ALK phos. And what they found when they followed these patients longitudinally, 1 out of 6 patients, or about 16% of the patients, develop PBC within 5 years. So if you have a patient with isolated AMA and normal ALK phos, don't forget about this patient. Usually is a guideline advocate to following them every 3 years, longitudinally till the age of 65. Another subgroup of PBC is what we call the AMA negative PBC. These patients tend to have a higher prevalence of other autoimmune antibodies, such as ANA and SMA. Usually we test for other specific antibodies, such as SP100 or GP210, depending what's available in your local lab. And this population tend to have lower serum IgM. IgM tend to be elevated in patients with PBC. This is where a liver biopsy is indicated, in my opinion, in management of in assessing these patients, where you would look at the histologic feature of PBC. And on biopsy, they tend to have more bile duct damage and loss, but luckily they respond to same therapy of PBC, whether with OCA or ursodiol. Another characteristic of this population, there is a higher prevalence of non-liver autoimmune condition. Fatigue tends to be the most common symptom seen in PBC. With more than 40% of the patient report actually moderate to severe fatigue that affects their quality of life. It tends to wax and wane. There is no relationship to to disease severity or prognosis. And it's a main complaint of patient when you see them in clinic. When evaluation fatigue in PBC patient, it's important to exclude other causes, such as anemia, thyroid disorder, diabetes, complication of medication, etc. And unfortunately, treatment of PBC does not affect the fatigue at all. There is no improvement of fatigue with the treatment of PBC with medication, with what we have now. However, it's not too depressing news. There was a recent study discussed and in publication now looking at fatigue intervention in patients with PBC. In a small study of 25 patients for 12 weeks, Dr. Freer and his colleague demonstrated that actually home-based exercise, passive resistance, very simple exercise regimen at home led to reduction in fatigue score in 23 out of 25 patients. So now it's in my practice, I actually tell patients, even though you have fatigue, you have to break the cycle. Any form of exercise usually help. And actually this is the only positive study for fatigue that I found in the literature. Pruritus is the second common cause, second common symptom seen in patients with PBC. And actually 30% of the patient could have moderate to severe pruritus that affects their quality of life and actually could lead to addictive behavior with scratching. It tends to have a diurnal variation. It's more intense in the evening. It's usually localized to the limbs, sole of the feet and palms of the hand. And usually it's exacerbated by heat, contact, and pregnancy. Management is usually supportive, use of emollient to prevent the dry skin, irritation, avoid hot water or heat if possible, exclude other allergen, and pharmacologically, cholestyramine is indicated as a first line of therapy. Unfortunately, it only works in 30% of the patient. So other therapy are used in management of patient with pruritus. Rifampin, for example, has been advocated for use, but you have to be careful as 10% of the patients who start rifampin are at risk to develop hepatitis. It's usually seen in the first 2 months of therapy. Another agent used is naltrexone. It's also associated with loss of appetite, weight loss, and more important, if a patient is on narcotic, you have to be careful using naltrexone. There is a lot of data in the literature about use of sertraline. It could lead to reduction in itching, but at the same time, weight gain is one of the common side effects, GI symptom, somnolence, and nausea. So therefore, we still need more therapy. So recently, the intrahepatic circulation of the bile acid caught the attention of pharmaceutical company. And there is multiple drugs being developed to interrupt the circulation, trying to improve pruritus in this patient. So let's talk about normal intrahepatic circulation. So bile acid in the liver is usually excreted into the small bowel through a transporter called the BSEP transporter. It makes its way into the terminal ileum, the bile acid, where it gets reabsorbed by another pathway using the IBAT, the ileal bile acid transporter. The bile acid then goes through the portal vein back into the liver, where it gets reabsorbed through another transporter called the NTCP transporter. When bile acid level achieve supraphysiological levels in the liver, they activate the FXR pathway, as demonstrated in the left cartoon of the slide. And that leads to increased expression of the BSEP transporter, so more bile acid is excreted back into the small bowel, and also inhibits the formation of bile acid from cholesterol by inhibiting the CYP7A1. So that leads to downregulation of bile acid synthesis, down expression of the NTCP, and less bile acid being formed. The other important factor about the system is actually higher level of the bile acid in the terminal ileum activate also the FXR receptor, lead to increased FGF19, activation of a receptor in the liver, which lead to inhibition of the rate-limiting step in the synthesis of bile acid, the CYP7A1. So if you move your attention to the right part of the slide, to the cartoon, you could see that inhibition of the IBAT system lead to downregulation of the NTCP receptor, so less expression. It will also decrease the formation of the bile acid and actually lead to increase in bile acid excretion into the small bowel and eventually into the stool. So less bile acid get reabsorbed through the terminal ileum. So the base of this inhibition led to the development of a IBAT inhibitor called Voloxibal. It's now being in clinical development. It's been shown to reduce pruritus by reduction of the serum bile acid. In a dose-ranging study, it proves that reduction in the bile acid, but the side effect was noted. As expected, if you have too much bile acid not being absorbed from the terminal ileum, GI symptoms becomes common, such as diarrhea or abdominal discomfort. And that was one of the side effects noted in the study. Currently, it's being moved into a phase 2 study and at the dose-ranging study, and everybody is eager to see the result of the study. Another agent is Lenoroxibal. It's another IBAT inhibitor being developed. It's been shown in a phase 2 study to reduce itching through the 5D itch scale as shown by 20% on the left side. And now it's being advanced into phase 3 study. Important part about the data presented from prior clinical trial for this agent is up to 64% of the patient actually developed diarrhea, and 10% of them actually withdraw from the study because of the abdominal pain or diarrhea. So more to see about whether this class of drug will survive given their side effect. Now, when we treat patients with PBC, we had some laboratory tests we used to monitor response. We usually use a combination of alkaline phosphatase or bilirubin. Recently, the global PBC group updated their data. This is a group that published the original study by Lammers and et al. That led to the adaptation of importance of bringing the alkaline phosphatase less than 2 upper limit of normal and try to normalize the bilirubin. In their updated study, they looked at patients with PBC and they divided them into 2 groups. Patients who had a normal bilirubin at entry into the study and patients who normalized their bilirubin 1 year after enrollment. The primary endpoint of the study was looking at liver transplant and all cause of mortality. The study found patients who were able to achieve normalization of the ALK-PHOS has significantly better outcome in terms of survival compared to people who had higher level of ALK-PHOS. And if you look at the cartoon between the dotted line and the solid yellow line, these are the group who have an ALK-PHOS above 1.67, upper limit of normal or less. And you could see there is no difference in survival between these 2 arms. So tell us that actually now we should aim to lower level of ALK-PHOS when treating of these patients. And same results were found when they looked at bilirubin in this group. Now, looking at bilirubin itself, achieving normal level of bilirubin is not enough in this population. This study showed actually by bringing the target of bilirubin to less than 0.6 upper limit of normal is associated with significant improved survival in this population. So if you look at the first bar, at the first graph on the left A, you can see the first level is less than 0.6 upper limit of normal. You have a survival at 15 years close to 90% compared to bilirubin within the normal range between 0.6 and 1, that's close to 70%, and people, as expected, who didn't normalize their bilirubin had a worse survival. So that's another lesson from this study that actually we should strive to lower the bilirubin even to a lower level than what's been used before. Looking at the data in a different way, looking at the 10 and 15-year survival, you could see patients who were able to maintain their bilirubin less than 0.6 as a 2 to 2.5 survival advantage compared to people who were not able to achieve this goal. So what do we have therapy for PBC now? We have 2 agents, ursodiol, everyone is familiar with, It works by diluting the bile acid pool, and obicolic acid, or OCA, which works through the activation of the FXR system, lead to inhibition of the bile acid synthesis, increase in secretion of bile acid, in addition to anti-inflammatory, antifibrotic property. The guideline advocate for the use of URSO as a first-line agent, but it's important to use it at the right dose. So before you deem a patient as a failure to ursodiol therapy, you want to make sure the patient is receiving the right dose of 13 to 15 milligram per kilogram per day. That's very important. And afterward, this is when obicolic acid is indicated as an add-on therapy to patients who don't achieve response to URSO, or for people who are intolerant to ursodiol, which is a minority of patients, 5%. And usually we measure response within 6 to 9 months of therapy, and we see whether the patient is responding to therapy and make a decision whether we need to intervene and add additional therapy. Monitoring response to therapies, there are many criteria depending which one you like. The Rotterdam has been used looking at the bilirubin, Paris 2 or Toronto. Basically, all these looks at the combination of AST, ALT, bilirubin in assessing response. Transient elastography has been also shown to have a value in patients with PBC. This is an old study, from 2012, so you could tell we're kind of 9 years behind, where it found that actually having one-time transient elastography study in these patients could have a prognostic value. For example, in this study, if a value of greater than 9.6 kPa is associated with 5 times more likelihood of having clinical decompensation, death, or transplant. The other value of transient elastography is you could follow the patient longitudinally, and you could actually calculate the rate of progression of the indirectly of the fibrosis, where a rate greater than 2.1 kPa per year rise is associated with the more advanced progression of the liver disease. Recently, we learned more about the long-term use of OCA. There was the open-label extension study data were released and discussed at the last liver meeting, and it actually confirmed what we expected. Patient who achieve a response to OCA therapy maintains that response for 6 years or more, as shown in the 2 graph in terms of alk-phos of bilirubin. But we also learned that pruritus remains a common side effect of this therapy, where in that data, 78% of the patient has mild pruritus, but only 4% led this discontinuation. But keep in mind, most of the patients in this study, more than 50%, had pruritus at entry into the study. Another update from the post trial is actually there is now histology data. So this is a study from Dr. Chris Bolles, where he looked at liver biopsy on 17 patients from the post trial at time of enrollment and at 3 years. And what he found that the majority of the patient actually maintains their level of fibrosis, their disease stable or improved. 12% showed improvement. And if you look at the right side of the slide, there's a collagen morphometry heat map, where red square is correlate with increased collagen deposition, and green square with less collagen deposition. So you could see at the bottom rectangle, in the follow-up, there is more green than red. So after 3 years, the 17 patient had actually suggestion of improvement of fibrosis under OCA therapy. So our current therapy is good, but not enough, unfortunately. Pruritus is a common problem. So in these patients, actually, this is one of the second most common complaint after fatigue. URSO is not a benign drug. It could lead to alopecia and abdominal pain, GI discomfort, etc. And you could see, most of the patients are women. If they develop alopecia, that's a big problem for them. And to make it more complicated, there's a change in the label update for OCA that was released last month. The label update emphasized that OCA, or obicolic acid, is now contraindicated in patients with a decompensated cirrhosis, child B or C, patient with prior decompensation, or if a patient has compensated cirrhosis, they should not have any evidence of portal hypertension, such as ascites, varices, or thrombocytopenia, and also re-emphasize the importance of not using OCA in patients with complete biliary obstruction. The label update also changed the dose of OCA in patients with cirrhosis. So now it only be used in patients with compensated cirrhosis without portal hypertension. So this is important. So patients should not have any history of, for example, of variceal bleed, ascites, hepatic encephalopathy, thrombocytopenia, or history of SBP. So if a patient fulfills this criteria, then you should start with 5 milligram daily, watch the patient for 3 months, and then assess, does the patient have adequate reduction in alk-phos or bilirubin? Do they still have no evidence of liver decompensation? And then make an assessment if you want to increase the dose to a max of 10 milligram daily. This is important because there was many case report published showing actually liver decompensation, worsening liver disease, even death in patients who received a higher dose of OCA, more than 5 milligram daily in patients with a child B or C, and that led to bad outcome. So it's very important to adhere to the label if you decide to use this drug in patients with cirrhosis. So in summary, the current therapy is good but not perfect. With URSO therapy, 40% of the patients shows inadequate response. It has minimal impact on pruritus. With OCA, 50% are inadequate responder, and that's known from the prior POISE study. Pruritus can worsen or be caused, and as always important, be cautious with the use of this drug in patients with cirrhosis. So we need a new therapy, and luckily we have multiple agents being developed. So we're going to talk about 4 of them. We're going to start with the PPAR delta agonist, ciladelpar. Activation of the PPAR delta leads to decrease in the bile acid by its effect on hepatocyte and cholangiocyte. It has anti-inflammatory property. It increases lipid metabolism, and that's one of the reasons why this class of drug was initially developed for fatty liver, and it has antifibrotic property by its inhibition of the stellate cell activation. So what do we know about this drug? In a phase 3 study, this drug was shown to achieve good response rate, where 78% of the patient met the composite endpoint of the study of bringing the bilirubin to below the upper limit of normal, improve in alk-phos, and reduction of alk-phos by more than 15%. For me, what was interesting about this drug is 50% of the patient had normalization of their ALT within a short period of time of 3 months, and there was significant reduction in pruritus. So you're affecting the PBC natural history as well as improving patient symptom of pruritus. Second agent is saroglitazar. It's a PPAR alpha with moderate gamma activity. Activation of the PPAR alpha site lead to decrease in bile acid synthesis, decrease in hepatic triglyceride, increase fatty acid oxidation with reduction of hepatic fat accumulation. It's also the target site for the action of the fibrate therapy. The delta activation lead to similar property, decrease inflammation, decrease free fatty acid, mitochondrial injury, and also has antifibrotic property. So in a phase 2 study of using combination of URSO and SARO versus placebo, there was a significant reduction in the alkaline phosphatase. About 50% reduction in the group who received the saroglitazar compared to placebo. And when you look at the composite endpoint, about 70% of the patient achieved this endpoint. So this is a drug is currently being advanced into a phase 3 study. Fibrate therapy is being used off-label in patients with PBC, and this is one small study looking at the addition of fibrate to people who don't respond to URSO. And patient was followed for 47 weeks, and the addition of fibrate therapy led to improved in transplant-free survival, normalization of the alk-phos, and slower disease progression to cirrhosis. Another property of fibrate, it also lead to improvement in itching in patients with PBC. How about using triple therapy? Now we have a new agent that make it into the United States. The bezafibrate is currently being developed in a clinical trial that we're going to be hearing more about in the coming few years. So this is a small pilot study of using this drug in 10 patients who have an incomplete response to OCA with URSO. And in this 10 patients, there was 7 out of 10 of the patient normalized their alk-phos, and 8 of the patient also were able to bring their bilirubin to less than 0.6, upper limit of normal. So now changing gear to PSC in the last 5 minutes. So like PBC, PSC is also another immune-mediated bile duct disease. It leads to progressive inflammation of the bile duct, eventually scar formation, and destruction of the intra and extrahepatic bile duct. On imaging, one could see, as everybody knows in this audience, you have a multifocal biliary stricture, and was thus developed with time. Patient eventually develops cirrhosis, portal hypertension. It's a disease of male predominance of young men aged 30 to 40. There is no signature autoantibody profile for this population, but we know from other studies that if a patient has a positive IgG4, this group of patients with PSC tend to have a more aggressive and progressive disease. We need imaging to make the diagnosis, but also important to exclude other causes of biliary injury, chronic cholangitis, biliary stricture, cholangiocarcinoma, etc., or IgG4 cholangiopathy. Within the last 2 years, the AGA published the practice guideline for management of patients with PBC. It emphasized the importance of screening for hepatobiliary cancer, especially in a patient with a large duct PSC and over the age of 20. Patient with a small duct PSC and younger than 20 years, there is no increased benefit for hepatobiliary cancer surveillance. And this is based on 2 studies of 250 patients with a small duct PSC and a young age. They follow these patients longitudinally, and there was only 1 case of cholangiocarcinoma reported in this population. So the guidelines don't advocate to screen for hepatobiliary cancer in this population. Now keep in mind, if a patient has cirrhosis, you have to screen for HCC in this population. Also important to assess for presence of gallbladder polyp due to a higher incidence of gallbladder cancer in this population. If a patient has a polyp greater than 8 millimeter, it's time to refer this patient for a cholecystectomy. And don't forget to screen for osteoporosis, because all patients with cholestatic liver disease have a higher incidence of osteoporosis development throughout their life. Liver stiffness is also used for monitoring these patients and for prognosis. And if a patient has a stiffness over 4.3 on initial evaluation, they have a higher rate of progression of their disease and requiring developing liver decompensation in the future. Same thing, you could measure the rate of progression of the fibrosis longitudinally to estimate the chance of the patient developing liver decompensation with time. This is a recent study published in CGH looking at the MRE in this population, where if a patient had a change of stiffness of greater than 0.34 kPa per year, they have a higher chance to develop liver decompensation. Ursodiol is making its comeback in the management of PBC. This is a small Japanese study where patients actually who received ursodiol have a higher survival advantage compared to people who didn't. But more important, there was about 70% reduction in the risk of developing biliary tract cancer in this population. So it kind of signals the benefit of ursodiol in PBC. So we're going to be hearing more and more about urso in the coming few years. We have no approved therapy for PSC. So remember, urso was removed from the recommendation after it showed increased mortality with higher dose, over 28 gram per kilogram. And we have a few drugs being developed. So we're going to talk about 2 classes, FXR agonist and the PPAR agonist. So the first one is cilofexor. It's a non-steroidal FXR agonist, where it showed the 3-fold reduction in a phase 2 study of the alkaline phosphatase. But it's, if you remember, OCA is also an FXR agonist. With cilofexor, the pruritus incidence was less, 14% in this study, compared to close to 50% with OCA. OCA was also studied in PSC in a phase 2 study. There was 21% reduction in the alkaline phosphatase, but 70% of the patient developed pruritus. This study was stopped, and OCA is not now being moved in any other study in PSC. Saroglitazar, the one we talked about, the PPAR alpha with moderate gamma activity, has been shown in animal model actually to improve inflammation in PSC animals as well as improve fibrosis. And to me, what was interesting from this abstract is when they did the histology, liver biopsy on these animals, the 7 out of 8 animals who were treated with Saro had complete reversal of PSC changes compared to none in the OCA group. Now, microbiome is also being studied in this population. This is a recent paper published in Gastro, actually this year, not last year. 2021 should be the reference at the bottom. It showed patients with PSC, they have a higher prevalence of Clostridium species in their stools, in addition to E. coli. And what was found, this population, that lower level of branched chain amino acid and vitamin B6, and extrapolation of these data, they showed in this study decreased survival of these patients and increased risk of liver decompensation. So in summary, now we have a new target goal in treating patients with PBC, where we should aim for normal alk-phos and bilirubin, less than 0.6 upper limit of normal. Elastography, transient elastography is now being used longitudinally to follow these patients with PBC and PSC. We have many drugs in development for PBC and PSC. We have a new therapy now emerging for treatment of pruritus. And we have many clinical trials that are going. So this is a summary of trials at Cedars we have. And we'll appreciate if you could send us your patient with PBC or PSC. Thank you for your attention.